Hi, my name is Giselle Avalos. Today I will be presenting on the autoimmune disorder systemic lupus erythematosus. I will be covering its history, causes, mechanisms, symptoms, diagnosis, and current treatments, all based on scientific research. So I will begin with an overview of lupus. Lupus is a chronic autoimmune disease, meaning the immune system mistakenly attacks the body's own tissues. The main problem in lupus is a dysregulated immune response that leads to inflammation and tissue damage. There are 4 types of lupus. There's lupus dermatitis, systemic lupus erythematosus, drug-induced lupus, and neonatal lupus. Lupus dermatitis affects the skin in the form of a rash. Systemic lupus erythematosus, also known as SLE, affects the internal organs and is the most serious type of lupus. Drug-induced lupus occurs as a result of an overreaction to a certain medication or medications. Examples of those medications are apresiline, which is a type of hydralazine, or quinidine. Drug-induced lupus is similar to SLE, but just not as severe. Lastly, neonatal lupus affects an infant as a result of passively acquiring antibodies from a mother who has SLE. In this presentation, the main focus will be on systemic lupus erythematosus. So, SLE is considered systemic because it can affect many organs, including the skin, joints, kidneys, and the brain. One key feature is that the disease follows a relapsing, re-emitting pattern, meaning that the symptoms will flare up, go away, and then they'll flare up again, and then maybe they'll improve over time, or it just really depends on the person. The main problem in lupus, again, is the dysregulated immune response that leads to this inflammation, and then when it gets worse, it affects the organs, leading to damage. So family history. So those who are higher at risk are those who have family members that have SLE. It's not contagious, but it is genetic. It can be genetic. Usually someone who has SLE in the family usually is the only one who has SLE. There's not multiple people who have it at the same time. The severity varies from person to person, and it poses a challenge in disease management. It's just hard to control because, again, it flares up, goes away. Sometimes it gets better or it gets worse. And this matters because it can affect vital organs and significantly impact the quality of life. It is a lifelong disease that requires continuous monitoring and treatment. It also represents a major healthcare burden due to a long-term medication use and complications. So the epidemiology of lupus. Just to refresh your mind, incidence measures the number of new cases of a disease, and prevalence measures the total number of existing cases of a disease, both at a specific point or population. So the incidence of lupus varies widely across the world depending on geography and population. The reported incidence and prevalence in North America is higher than in some other countries, with Africa reporting the lowest. Certain ethnic groups, such as African American, Hispanic, and Asian populations, have a higher rate of acquiring SLE and often have it more severe. So global incidence of SLE is about 5.14 per 100,000 people, with the highest reportance of incidence in Poland, USA, Barbados, and China. And the global prevalence of SLE is about 43.7 per 100,000 people, which is highly reported in the United Arab Emirates, Barbados, and Brazil regions. So the demographics of SLE, age, gender, and ethnicity play a significant role in determining clinical outcome and management of the disease. SLE predominantly affects women during childbearing years or during those ages. It's a ratio about 9 to 1 compared to men. This is especially true, again, during the reproductive years, suggesting that hormones like estrogen may play a role in the immune system activation. Additionally, genetic and immune system differences between males and females may contribute to the increased susceptibility. Ethnicity, so Black, Asian, and Hispanic populations show higher susceptibility to SLE. It's far less common in Europeans compared to other ethnicities. and it mainly affects young adults with a peak incidence in women, again, aged 15 to 44 years old. Both perspectives of lupus. The term lupus comes from the Latin word wolf because physicians thought that the facial rash resembled a wolf bite. Lupus was not fully recognized as an autoimmune disease until the 20th century, until the advances of immunology revealed that the immune system was attacking its own tissues. Lupus can be dated back to 400 BC and divided into 3 periods: the classical, neoclassical, and the modern period. In the classical period, Hippocrates firstly described the possible ulcers of SLE and identified them as a cutaneous disorder. In the neoclassical period, this is where a lot of the therapeutics were introduced. This is where the first medication, quinine, was used, and all of the cortisones were used. In the modern period, the discovery of the lupus cell took place, but before the discovery of the LE cell, the lupus erythematosus cell, the syphilis test, Wassermann test, was used for diagnosis. And then we had just an advancement of technology, which was the immunofluorescence for ANA detection, then the establishment of marine models, and then all the contributions to the history of the SLE research allowed for the lifespan of the SLE patients to be extended 5 years after initial diagnosis to living with the illness. So the pathology, SLE involves the formation of immune complexes, which are combinations of autoantibodies and antigens. These complexes deposit in tissues and blood vessels, causing the inflammation and the severe organ damage. So the mechanism of normal immunity versus autoimmunity. So normal immune function recognizes and responds to foreign antigens while remaining tolerant to self-antigens, achieved through immune tolerance. Activation for normal immunity is driven by foreign antigens presented through co-stimulatory signals. For autoimmunity, this occurs when the immune system fails to distinguish self from non-self, leading to activation of autoreactive T and B cells that attack the body's own tissues. Activation for autoimmunity is through molecular mimicry, loss of self-tolerance, or environmental triggers that alter self-antigens. So here is the normal immunity kind of summed up of what I just explained. And then now here is the pathogenesis of systemic lupus erythematosus. So on the far left, lupus begins with a combination of genetic susceptibility and environmental triggers. These environmental triggers often include UV light or UVB light, which I will mention later, infection, smoking, and hormonal influences. Next, in section 2, we see loss of self-tolerance, which is a key turning point for SLE. Normally, the immune system ignores the body's own cells, but here, the control for that is lost. So dead and dying cells release nuclear material like DNA and RNA, and the body doesn't clear it properly, so the buildup of that becomes a major trigger for the immune system. So now with all the buildup, the innate immune system becomes activated. Dendritic cells recognize the nuclear material, so like the DNA and the RNA, through the receptors TLR7 and TLR9. This leads to the production of type 1 interferons, which are one of the most important cytokines in SLE, and they're a powerful inflammatory signal. These interferons amplify the immune response and activate more immune cells. So now this brings us to the adaptive immune system, where the autoreactive T cells become activated and escape normal regulation. At the same time, B cells receive help from the T cells and become activated. So normally Treg cells or regulatory T cells would suppress this, but in lupus, those Treg cells are not functioning properly. Activated B cells then differentiate into plasma cells, which produce autoantibodies. These include antibodies against DNA and other nuclear components, which are a hallmark of lupus. These autoantibodies bind to self-antigens to form immune complexes. These complexes circulate in the bloodstream and eventually deposit into the tissues. Once they're deposited into the tissues, the immune complexes activate the complement system and recruit more inflammatory cells, which then leads to tissue inflammation, cell damage, and eventually organ dysfunction. So as mentioned in the previous slide, cytokines, or specifically interferon type 1, is really crucial to how SLE works. So interferons are a group of cytokines that include multiple subtypes of interferon alpha, beta, omega, kappa, and epsilon. In SLE, dysregulated production of type 1 interferons stimulate the activation of APCs. They lead to antigen presentation and T cell activation that promote the expansion of autoreactive T cell populations. They enhance the survival and the activation of B cells and promote the differentiation into autoantibody production. They also affect the balance of T helper cell subsets, specifically Th1 and Th17, which contribute to tissue inflammation and autoantibody production. Interferon 1 can amplify its own signaling pathway in SLE, which induces the expression of ISGs, which are interferon-stimulated genes that target immune cells and tissues, which further enhance the production of inflammatory. So it was also shown in a study with a mouse that the absence of this type 1 interferon receptor protected against the development of SLE. Okay, so getting into the triggers for SLE, these are known as environmental triggers such as infections, specifically EBV. EBV is the Epstein-Barr virus. It's a type of herpes with the elevated EBV IgA antibodies. This leads to abnormal B cell activation and autoantibody production. There's also cigarette smoke components such as nicotine, carbon monoxide, and free radicals can induce oxidative stress and directly damage DNA and proteins that lead to genetic mutations. Then we have exposure to ultraviolet light, specifically ultraviolet B, which is found in direct sunlight when UV index is high, tanning beds, light therapies, which are typically found in medical and spa devices. And there's also mercury vapor lighting, which is on stadium lights and gym lighting. Certain drugs that implicate the development of SLE are hydralazine, specifically. These are usually medications that regulate high blood pressure. And then some hormonal triggers such as estrogen and progesterone are just commonly seen in women, so that could explain why it's more seen in women. And these hormonal triggers do not act alone. They're usually accompanied with any other type of environmental trigger. Okay, so symptoms and clinical presentation. There's a broad spectrum of symptoms ranging from mild to severe to life-threatening. Everybody presents different. So we can have skin symptoms from left to right are on the bottom is the malar rash, alopecia, discoid lesions, and then my video is showing the oral ulcer, but it's just like one of those ulcers you get in the inside of your lip, like on the roof of your mouth in the hard palate. You can also get musculoskeletal symptoms, renal, neurological, cardiovascular, pulmonary, hematologic, and others such as fatigue, fever, weight loss, anything like that. The definite diagnosis of SLE is challenging because it is a complex multisystem disease. Currently, it's diagnosed by both clinical manifestations and laboratory examinations, where SLE manifestations are defined by subjective and objective findings, subjective being headaches, chest pains, objectives being electrocardiographic or echocardiographic confirmation of cardiac comorbidities. There are 3 classification criteria used. First is the 1997 version ACR classification, which is used for SLE diagnosis. It classifies molar rash, discoid rash, and photosensitivity, also the oral ulcers. The 2012 Systemic Lupus International Collaborating Clinic, so SLICC, was introduced to overcome the issues faced with the 1997 version ACR. Because a 1997 version lacked cutaneous and neuropsychiatric manifestations. The 2019 European League Against Rheumatism and the American College of Rheumatology, so the EULAR, is mainly just a classification tool rather than a diagnosis. It's just there to enhance the the classification criteria of the both previous criteria. So for mild cases, initial treatment typically includes anti-inflammatory drugs and anti-malarial medications. For severe cases, those are the ones with organ involvement. They range from glucocorticoids and immunosuppressive therapies. For pregnancy, hydroxychloroquine is considered relatively safe. It is used alone or in conjunction with steroids and immunosuppressive agents. The choice of drugs and treatment depends on the disease's activity. So for current research, the main topic is targeted therapies, which are cellular therapies, and the anti-CD19 CART cell therapy. So the anti-CD19 CART cell therapy has an important downregulation effect on the type 1 interferon serum levels, and as well as its signature T cells, which again, understanding interferon 1 in SLE leads to the development of targeted therapies, because it is very important to inhibit that in order to stop the way that SLE works and proceeds. Okay, so the management and the long-term complications of lupus has improved, but because lupus is still not well understood and there's still ongoing research, there aren't very specific treatments available. There's just many unspecific treatments, but again, there's just ongoing research that needs to be done in order to find specific treatments for the specific types of lupus that people present with. That's all for this presentation, and I hope that y'all enjoyed everything. Thank you.